Hello and welcome to the topic Normal and Abnormal Labor in the module Obstetrics and Gynecology. By the end of this session, you should be able to define normal and abnormal labor, explain the mechanisms of labor, describe the stages of labor, recognize the presentation of normal and abnormal labor, identify the investigations done in the workup and management of normal and abnormal labor, and finally, discuss the principles of management of normal and abnormal labor. Let's get started. So, what is labor? Labor is a physiologic process during which the products of conception, which is the fetus, membranes, and umbilical cord, as well as the placenta, are expelled outside of the uterus. Labor is a clinical diagnosis. The onset of labor is defined as irregular, painful uterine contractions resulting in progressive cervical effacement and dilatation. Let's look at the mechanism of labor. The ability of the fetus to successfully negotiate the pelvis during labor involves changes in position of its head during its passage in labor. The mechanisms of labor, also known as the cardinal movements, described in relation to a vertex presentation, as is the case in 95% of all pregnancies. The first step is engagement. The widest diameter of the presenting part with a well-flexed head where the largest transverse diameter of the fetal occiput is the biparietal diameter enters the maternal pelvis to a level below the plane of the pelvic inlet. After that, it descends, and in descent, the downward passage of the presenting part through the pelvis is what we call descent. This occurs intermittently with contractions. The rate is greatest during the second stage of labor. Next, we have flexion. As the fetal vertex descends, it encounters resistance from the bony pelvis or the soft tissues of the pelvic floor, resulting in passive flexion of the fetal occiput. The chin is brought into contact with the fetal thorax, and the presenting diameter changes from occipitofrontal to suboccipitobregmatic for optimal passage through the pelvis. Moving on, we have internal rotation. As the head descends, the presenting part usually is the transverse position, is rotated about 45 degrees to antero-posterior position under the symphysis. Internal rotation brings the AP diameter of the head in line with the AP diameter of the pelvic outlet. Next is extension. With further descent, the full flexion of the head, the base of the occiput comes in contact with the inferior margin of the pubic symphysis. Upward resistance from the pelvic floor and the downward forces from the uterine contractions cause the occiput to extend and rotate around the symphysis. This is followed by the delivery of the fetus's head. Next, we have restitution and external rotation. When the fetus's head is free of resistance, it untwists about 45 degrees left or right, returning to its original anatomic position in relation to the body. And finally, expulsion. After the fetus's head is delivered, further descent brings the anterior shoulder to the level of the pubic symphysis, and the anterior shoulder is then rotated under the symphysis, followed by posterior shoulder and the rest of the fetus. Now, let's take a look at the stages of labor. So, stages of labor are divided into 3 when there's no associated complications seen. For the first stage of labor, it begins with regular uterine contractions and ends with complete cervical dilatation at 10 centimeters. It is divided into the early latent phase and ensuring active phase. In the early latent phase, it begins with mild, irregular uterine contractions that soften and shorten the cervix. The contractions become progressively more rhythmic and stronger. In the ensuring active phase, it usually begins at about 3 to 4 centimeters of cervical dilatation and is characterized by rapid cervical dilatation and descent of the presenting fetal part. The first stage of the labor ends with complete cervical dilatation at 10 centimeters. Characteristics of average cervical dilatation curve is known as the Friedman labor curve and is a series of definitions of labor protraction and arrest were subsequently established. Next, let's move on to second stage of labor. The second stage of labor begins with complete cervical dilatation and ends with delivery of the fetus. It is suggested that a prolonged second stage of labor should be considered when the second stage of labor exceeds 3 hours if regional anesthesia is administered or 2 hours if in the absence of regional anesthesia for nulliparous patients. In multiparous women, such a diagnosis can be made if the second stage of labor exceeds 2 hours with regional anesthesia or 1 hour without it. Maternal risk factors associated with a prolonged second stage include nulliparity, increasing maternal weight and/or weight gain, use of regional anesthesia, induction of labor, fetal occiput in a posterior or transverse position, increased birth weight. Finally, we have third stage of labor. The third stage of labor is defined by the time period between the delivery of the fetus and the delivery of the placenta and fetal membranes. During this period, uterine contractions decrease basal blood flow, which results in thickening and reduction in surface area of the myometrium underlying the placenta with subsequent detachment of the placenta. Although delivery of the placenta often requires less than 10 minutes, the duration of the third stage of labor may last as long as 30 minutes. So when it comes to management, expectant management is advocated and involves spontaneous delivery of the placenta. There could be active management as well, where it involves prophylactic administration of oxytocin or other uterotonics such as prostaglandins or ergot alkaloids, cord clamping or cutting, and controlled cord traction of the umbilical cord. The third stage of labor is considered prolonged after 30 minutes, and active intervention such as manual extraction of the placenta is commonly considered. Now let's take a look at the clinical presentation. The initial assessment should include a review of the patient's prenatal care, including confirmation of the estimated date of delivery. A focus history taking will include the frequency and time of onset of contractions, the status of the amniotic membranes, whether the amniotic fluid is clear or meconium stained, if the membranes have ruptured, fetus's movements, and presence or absence of vaginal bleeding. There is another concept called Braxton Hicks contractions. So these are often irregular and do not increase in frequency with increasing intensity and must be differentiated from true contractions. Usually, it resolves with ambulation. Braxton Hicks contractions are usually no more than 1 to 2 per hour, and they often occur just a few times a day. Contractions that lead to labor tend to last longer and are more intense, leading to cervical change. So true labor is defined as uterine contractions leading to cervical changes. If contractions occur without cervical change, it is not labor. When it comes to physical examination, the basic examination that you will need to do would include patient's vital signs, fetus presentation, assessment of fetal well-being, and frequency, duration, as well as intensity of uterine contractions. We then can proceed with the Leopold's maneuver, which is the abdominal examination. The first maneuver is where the examiner places both of his or her hands on each upper quadrant of the patient's abdomen, gently palpating the fundus with the tips of the fingers to define which fetal pole is present in the fundus. If it is the fetus's head, it should feel hard and round. In a breech presentation, a large nodular body is felt. The second maneuver is when the palpation is in the para-umbilical region with both hands by applying gentle but deep pressures. The purpose is to differentiate the fetal spine. This will help to determine the position of the fetus. Next is the physical examination findings. So the basic signs that you will need to collect in the beginning would include patient's vital signs, fetus presentation, assessment of fetal well-being, and of course, the frequency, duration, and intensity of uterine contractions. So then you can also perform the abdominal examination, also known as the Leopold's maneuver. The first maneuver is when the examiner places both of his or her hands on each upper quadrant of the patient's abdomen and gently palpates the fundus with the tips of the fingers to define which fetal pole is present in the fundus. If it is the fetus's head, it should feel hard and round, and in a breech presentation, a large nodular body is felt. The second maneuver is when palpation is over the paraumbilical regions with both hands by applying gentle but deep pressure. The purpose here is to differentiate the fetal spine and to determine the fetus's position. So for the third maneuver, a suprapubic palpation is done by using the thumb and fingers of the dominant hand. As with the first maneuver, the examiner ascertains the fetus presentation and estimates its station. If the presenting part is not engaged, a movable body can be felt. This maneuver also allows for an assessment of the fetal weight and the volume of amniotic fluids. And finally, the fourth maneuver, which is the palpation of bilateral lower quadrants with the aim of determining if the presenting part of the fetus is engaged in the mother's pelvis. The examiner stands facing at the mother's feet. With the tips of the first three fingers of both hands, the examiner exerts deep pressure in the direction of the axis of the pelvic inlet. In a cephalic presentation, the fetus's head is considered engaged if the examiner's hand diverge as they trace the fetus's head into the pelvis. And finally, you would want to do a pelvic examination as well as a digital rectal examination or vaginal examination. All pregnancies require a thorough evaluation of risk and close surveillance. As soon as the mother arrives at labor and the delivery suite, external tocometer monitoring for the onset and duration of uterine contractions and use of a Doppler device to detect fetal heart tones and rate should be started. In the presence of labor progression, monitoring of uterine contractions by external tocodynometry is often adequate. However, if a laboring mother is confirmed to have rupture of the membranes and if the intensity or duration of the contractions cannot be adequately assessed, an intrauterine pressure catheter can be inserted into the uterine cavity past the fetus to determine the onset, duration, and intensity of the contractions. Bedside ultrasound may be used to assess the risk of gastric content aspiration in pregnant women during labor by measuring the antral cross-sectional area. Cardiotocography, which is an electronic fetal monitoring device, can be used if non-reassuring fetal heart rate tracings by cardiotocography are noted. A fetal scalp electrode may be applied to generate sensitive readings to beat-to-beat variability. Routine laboratory studies such as full blood count, blood typing and screening, and urine analysis are also done. And not to forget, always ensure that there is an intravenous access established. There are two methods of augmenting labor which have been established. The traditional method involves the use of low doses of oxytocin with long intervals between dose increments. For example, low-dose infusion of oxytocin is started at 1 milli international unit per minute and increased by 1 to 2 milli international units per minute every 20 to 30 minutes until adequate uterine contraction is obtained. Well, when does one need augmentation? So if active labor has started on its own but contractions have slowed down or completely stopped, steps need to be taken to help labor progress, which is augmentation. Augmentation will be done when active labor has started, but your contractions are weak or irregular or have stopped entirely. You have gone into active labor, but the amniotic sac has not ruptured on its own. In this case, your doctor or nurse midwife may rupture the amniotic sac to augment the labor. And if labor still does not progress oxytocin may be given to make the uterus contract. Active labor has started and the amniotic sac has ruptured on its own, but labor is still not progressing. Here, you will need to augment the labor by administering oxytocin. This will help the uterus contract. Thirdly, if labor has failed to progress in spite of membrane sweeping and amniotomy, oxytocin, or a combination of these measures, delivery by C-section may be considered. Now, let's look at the definition of abnormal labor. So, abnormal labor or difficult labor or abnormally slow progress of labor are among the various definitions of abnormal labor. In other terms, it is dysfunctional, it fails to progress, and there is a pelvic disproportion. There are a couple of indicators that provides us information about abnormal labor. These include period of prolonged latent phase, average second stage, prolonged second stage period, and others as listed here. These are not compulsory to be remembered at this stage. However, be familiar with the criteria or indicators that obstetricians use to confirm abnormal labor. Next, let's now look at the factors that contribute to an abnormal labor. There are three in general, the three P's, which are the passenger, pelvis, and power. Let's look at the passenger. The passenger may produce abnormal labor because of the infant's size, such as in a macrosomic state or from malpresentation. The second P is pelvis, which can cause abnormal labor because its contours may be too small or narrow to allow passage of the infant. Both the passenger and the pelvis cause abnormal labor by a mechanical obstruction referred to as mechanical dystocia. And the third P is the power component. The frequency of uterine contraction may be adequate, but the intensity may be inadequate. So disruption of communication between adjacent segments of the uterus may also exist, resulting from surgical scarring, fibroids, or other conduction disruption. The cause would cause the contraction pattern failing to result in cervical effacement and dilatation, and this is called functional dystocia. So how do we approach a patient with abnormal labor? Upon admission to the labor and delivery unit, determine and document clinical findings. Clinical pelvimetry, which is best performed at the first prenatal care visit, is important in order to assess the pelvic type, whether it's android, gynecoid, platyploid, or anthropoid. Evaluate the position of the fetal head in early labor because caput and molding complicate correct assessment as labor progresses. Establish and document an estimated fetal weight. Monitor the fetal heart rate and uterine contraction patterns to assess fetal well-being and adequacy of labor. Perform a cervical examination to determine whether the patient is in the latent or active phase of labor. By addressing these issues, it allows for an assessment of the current phase of labor and anticipates of whether abnormal labor from any of the three P's may have been encountered. So do always keep in mind and have differential diagnosis when you come across an abnormal labor, because some of it would be amnionitis, false labor, malpresentation, obstruction due to myomas or cervical stenosis, or uterine anomalies. There are no specific lab tests that can be done to assess an abnormal labor. To evaluate abnormal labor is to plot the patient's labor progress, which is the cervical dilatation versus duration in hours on a labor curve. The test used to address adequate labor is the review of the uterine contraction pattern by determining adequacy of contractions with use of an intrauterine pressure catheter. Most importantly, the fetal heart rate tracing must be reassuring throughout the labor course. An estimate of the fetal weight must be documented in the hospital chart early in the labor course. If concern for macrosomia exists, this must be addressed with the patient and the labor or the delivery team in order to anticipate and prepare for labor dystocia. Next, let's look at medications. So, oxytocin is used to induce labor. Active management of labor can be applied to nulliparous women with singleton cephalic presentation at term. This method involves the use of high-dose oxytocin with a starting rate of 6 million units per minute and increasing by 6 million units per minute every 15 minutes to a maximum of 42 units per minute. The goal is to have no more than 7 uterine contractions per 15 minutes. Under this higher dose protocol, caesarean delivery is performed if vaginal delivery has not occurred or is not imminent 12 hours after admission or for fetal compromise. Low-dose administration of intravenous propranolol in abnormal labor augmented with oxytocin reduce the need for caesarean delivery, particularly among patients with inadequate uterine contractility. Dinoprostone and misoprostol are prostaglandins analogues used to stimulate cervical dilation and uterine contractions. When we look at surgical intervention, on the other hand, amniotomy is often used and has become an accepted practice once the patient has reached the active phase of labor, although it has not been shown to result in shorter labor. This practice is not recommended in the latent phase of labor because it may only serve to increase the risk of intrauterine infection or cord prolapse. In the case of the prolonged second stage due to fetal malposition, the operator may attempt manual rotation of the fetal occiput. If one of the arrest or protraction disorders are identified and fails to respond to conservative measures, or if the fetal heart pattern is non-reassuring, expedite delivery is justified. This includes operative vaginal delivery or caesarean delivery as indicated. Operative delivery with use of forceps or vacuum must be performed by an experienced provider. Be aware of the increased associations of shoulder dystocia and neonatal injury with operative vaginal delivery in the setting of abnormal labor. Now, to recap, normal labor is a physiologic process during which the products of conceptions are expelled out of the body, and abnormal labor is a difficult labor or abnormally slow progressing labor. Remember the 6 steps that take place during labor, which are engagement, descent, flexion, internal rotation, extension, restitution and external rotation, and finally expulsion. Not forgetting the stages of labor as well, which are the first, second, and third stages of labor, and recap on the factors that lead to abnormal labor ways on recognizing them in your practice. We have come to the end of this session. Thank you for your time.